Good evening, everyone. My name is Terry Bauer, and I'm CEO of Specialdocs Consultants. I am delighted and honored to be here with some of the finest physicians in the United States, if not beyond. And we're going to be speaking tonight a bit about the Cancer Research and Treatment Fund, as well as some of the things that they do at the Weill Cornell Medicine organization in New York. I will introduce the participants briefly by name, and then they will go ahead and talk a little bit about their backgrounds. We will then ask the group some questions, and then we will wrap up at the end. So I'm going to start with Dr. Ghaith Puglisi. Jeff, welcome. Tell us a little bit about yourself.
Thanks, Terry, so much. It's a pleasure and a privilege to be here tonight. The Cancer Research and Treatment Fund is something that is near and dear to my heart. I'm an internal medicine, concierge medicine doctor in Greenwich, Connecticut, and I've done so for the past 19 years from this area in Westchester County. But I'm wearing two hats tonight. The first hat is of a physician that treats patients with many different conditions, some of which include the hematologic, oncologic issues we'll talk about tonight. But I'm also wearing another hat, and that's of a patient. And that's a patient who's had a diagnosis of polycythemia vera, one of the MPN cancers that we're talking about, for the past 18 months. And I'm very, very relieved and lucky and honored to be a patient of one of the physicians that's on the panel tonight. You'll meet him in a minute. And I was introduced to this group because of the efforts that the CR&T fund had last year. I went to a couple of different educational patient symposiums and research symposiums down in New York City at Weill Cornell. And I was blown away by the people that I met and by the physicians that I met and the researchers that I met. And I knew that I needed to get involved. And so in addition to me taking care of patients here as a physician and trying to do the best I can to take care of myself, I wanted to make sure that I had the best and the brightest in the country, making sure that I have a long and healthy and prosperous life going forward. And so I'm just really happy to be here. And thanks again for moderating tonight.
Great, Jeff. Jeff, thank you for participating and for sharing your story. Ghaith Abu-Zeinah is a physician, instructor in medicine at Weill Cornell Medicine. Ghaith, introduce yourself to the audience and tell us a little bit about yourself.
Yes, thank you, Terry, for hosting. It's definitely a pleasure to be here. My name is Ghaith Abu-Zeinah, and I'm originally from Jordan. Actually did all my medical training in Cornell. I started off in Weill Cornell in Qatar, then moved to the US to do my internal medicine residency at Weill Cornell here in New York. And then I did my hematology and oncology fellowship also here at Cornell. And I've been fortunate enough, obviously, to have a great mentorship here and the great support that I've received from CR&T to be able to continue my path as a physician scientist in the field of myeloproliferative neoplasms. Great.
Thank you, Ghaith. We're delighted to have you join us this evening. Next on the dais here is Joe Scandura. Joe is a MD, PhD. He's Associate Professor of Medicine, and he's Scientific Director of the Richard T. Silver, MD, Myeloproliferative Neoplasm Center at Weill Cornell Medicine. Joe, great to have you. Tell the audience a bit about yourself.
I'm a Scientific Director of the MPN Center, as you had indicated. I came through to Cornell as an oncologist after completing my training at Sloan Kettering. I've been treating almost exclusively myeloproliferative diseases as an outpatient for almost 20 years. And my laboratory has studied blood formation for throughout that period of time. And the two have interleaved well in my career. I've continued to play an active role in the care of patients, which I take as a quite serious part of my life and development. And I also continue to run an active laboratory research program and clinical research program.
Thank you, Joe. Great to have you with us. Ghaith, I'm going to go back to you and tell the audience a little bit about why you focused on hematology oncology with a dedication to the myeloproliferative neoplasm area.
Oh, of course. So I chose this field because I think the biology of MPNs is truly fascinating. I think there is a high degree of complexity in the biology of myeloproliferative neoplasms that we haven't resolved yet. And my goal is to be to contribute to resolving that complexity in order for us to be able to find treatment that can cure this disease. So partly driven by my interest in the biology of MPNs, but I do have to say that one very important and main aspect that led me to choosing this field is really the patients themselves. I think through my career in general medicine and even hematology and oncology, I don't believe I've seen any group of patients who are sort of more interested and curious about their disease than the MPN patients. And that sort of interest and curiosity, I would say a healthy level of anxiety about health, actually makes the MPN patients, in my opinion, very compliant. So it's definitely a group of patients that I've had, really the pleasure of taking care of. And that's really driven me into getting into this field, not only as a clinician, but as a clinician scientist who studies this disease in the lab and also treats patients in the clinic.
Thank you, Ghaith. Joe, maybe for the audience's edification, talk a little bit about how many people this affects and maybe some of the history and the trends of NPN. Maybe that'll help the audience level set and what you're focused on, and then talk about why you got into this area and why you specialized in this area.
So myeloproliferative neoplasms are a class of diseases. They're really characterized by two findings. One is relatively normal structure of the cells and largely preserved function of the cells, yet overproduction in excess of what is needed, and that's what causes many of the problems. The cells produced often have some sort of hyperexcitability that can contribute to some of the morbidity. The most common myeloproliferative neoplasms are really four: chronic myelogenous leukemia, for which there's been tremendous advances in therapy and has really, in my career, has been transformed from a progressive and ultimately fatal disease to one for much more treated like diabetes, chronic condition, often treated to the point where the disease is no longer identifiable. The other three main myeloproliferative neoplasms are essential thrombocythemia, polycythemia vera, and myelofibrosis. And those are relatively rare diseases and affecting a few tens of thousands of Americans. One of the issues are, because these are blood diseases, and by virtue of the universality of blood to every tissue, they can have very wide-ranging effects on patients. Symptoms commonly affecting patients: fatigue, sometimes abnormal enlarged spleen causing discomfort, and a variety of potential complications, some of which can be medically serious, including a predisposition to clots. These diseases, because of their complexity and are ones, and rareness, are ones that are not seen by many physicians in the community, hematology oncology specialists. And it's one of the reasons why years ago, CR&T, or Cancer Research and Treatment Fund, decided to honor Richard T. Silver by naming a center in his honor to focus on the science behind and clinical care of myeloproliferative neoplasms. And that's part of the reason why I'm here and Ghaith is here, is to fulfill that promise. My personal path to myeloproliferative neoplasms in many ways comes from my studying blood formation for most of my professional career. Normal blood formation is a very close cousin of myeloproliferative neoplasms. And when you look at the differences in the genetic standpoint, they often come down to one mutation or a couple mutations. And that offers the promise of simplicity and potential cure. and that's a motivation for us. However, the scientific reality of it is that these diseases are far more complex than the single genetic mutations we know about. And that's where the drive and the role of a dedicated center comes to bear on this misleadingly complex problem.
Thank you. Guy, tell us a little bit about your perspective on why is it valuable for patients to work with a physician who combines both research and clinical practice?
Sure. I think the research component is really essential and critical for our understanding of the disease and how to treat the disease. I think research is important for us to be able to understand not only how the disease progresses, but most importantly, how can we prevent it from progressing, potentially reversing the disease from its natural course, and ultimately aiming for treatment that can cure this and eradicate the disease. You know, without research, we won't be where we are now. We wouldn't know the kind of things that we know now about treatment that have been used, 30, 40 years ago that later turned out to be toxic. So research has really helped us not only to develop a treatment that could be effective, but also safe treatments to give to patients. So generally when we do research, and especially clinical trial research looking at treatment, our first goal is to be able to identify a treatment that is safe for patients. So that's where the importance of research is to be able to develop new treatments safely, and then be able to take those treatments into larger studies to examine how effective they are and whether or not they ultimately achieve the goal that you're hoping to achieve, which is putting the disease in remission and curing it. Now, this is in reference to clinical research. That's a little bit different than basic science research and translational research. At the end of the day, it's all studies and investigations to get to the bottom of understanding the disease biology and how to treat it. But the difference in the basic science or translational research is that we often conduct the research in the laboratory as opposed to the clinic. So conducting research in the laboratory is important because that's where these novel treatments are first conceived. Before you introduce a new treatment or drug to the clinic, you have to be able to demonstrate that in the laboratory, it has some signal of effectiveness in order to be able to utilize resources appropriately and not to subject patients to unnecessary research unless you know for sure that the agent or the drug that you're testing has some potential benefit in the laboratory before you bring it forward to the clinic. So I think, the bottom line is research is important because it helps us understand the disease better, and it helps us come up with more effective treatments that ultimately make patients feel better and live longer.
Excellent, excellent, thank you. Jeff, so you alluded to this at the beginning. You come at this from a very unique angle. Highly accomplished, successful internal medicine physician. You are on the board of the CR&T, the Cancer Research and Treatment Fund, and you're a patient. So you're uniquely qualified to provide your perspective on what it's like to work with this organization, work with these two outstanding physicians, and also knowing as much as you know and the type of person that you are, the research that you've done to find these folks and to find this center. So tell the audience a little bit about your perspective and your journey, how you got here, and what you've learned.
It's a great question, Terry. It's something that I don't share too frequently with patients of mine. I'm really more concerned about what's going on with them than sharing all details about what's going on. But this is an important moment for me because for patients that are watching, for family that's watching tonight, other clinicians that I know throughout the country, there are two messages that I want to send. Message number one is that when a patient of yours has vague, chronic, unexplained symptoms, you just don't stop. You have to advocate for that patient. And that's a situation that happened to me over the past couple of years, is that there were symptoms that were bothering me. And every single person that I saw said, "You look great, Jeff. Your labs are fine. Not sure what's wrong with you. Maybe it's just stress of, being a concierge doctor and taking care of a lot of patients and bringing on a new physician or whatever it might be." And I just want people to stop for a moment, especially the doctors that are listening tonight, and just think about the patients that they have of every age group that you can't quite unravel exactly what the root cause and the etiology of their symptoms are. You hope it's nothing serious, but you're just not sure. And I think that this is a testament to a patient being their own advocate, finding a physician that is both compassionate but has the time to listen. And that's kind of what happened to me. Over the past year and a half to 2 years, I just banged down the door of a lot of physicians and others and let them know about what I was going through and wasn't bashful about it. Too frequently, physicians, and Joe and Ghaith can attest to this, we just grin and bear it, and we run to the next patient and we figure out what's wrong with them, and we just hope that whatever's going on with us is just going to continue to improve. I think many physicians have that mantra that they really don't want to dive into their own health, and I've been a big proponent of walking that walk. And if I say to somebody that I want them to be healthy and do the right thing, I want to try to do it myself too. It's kind of the reason why about 5-6 years ago I switched over to a concierge practice, partly to have more time to take care of myself and to unravel some of the mysteries that were going on and symptoms that I had. I met with a physician and a physician assistant actually down in New York City at the Comite Center, and Lauren Klein is the physician assistant that I met with there too. And she said to me, "Jeff, a couple of the symptoms that you have," some of it was intolerance to heat and sun, and I'm a big golfer and I love to be outside, but I was really wilting like a flower. And some of the skin issues that I had, and some of the fatigability and optic migraines and other subtle things that you could just attribute to 100 different causes. She said to me, and I'll remember it like it was yesterday, she said, "A couple of my patients that I had in my practice previous to this had P. vera, and maybe we should just test for it. And yeah, your hemoglobin and hematocrit and red blood cell count aren't that high, but there's a genetic test to look for it, and why don't we just send it? We're sending other blood work, let's just look for it." And boom, changed my life forever, saved my life, quite frankly. Because if I go on the next number of years not knowing this, there's a very high likelihood that I could have gotten a clot from my blood getting very viscous from having too many red blood cells. And I credit her and that team for really pushing me into this world of understanding what was wrong with me, and then trying to identify who should it be that manages this care, because it can't be me. I'm not an expert in this. I'm not doing bench research on it. And so, it was just fortuitous that I was able to spend 3 days down in New York City at Weill Cornell at the Silver Center for MPM, and met everybody that we're talking to tonight. And that was a light bulb moment. And I knew for a fact that Ghaith was going to be the doctor that I would entrust my care to. And it's been amazing, this journey. And we've been able to see each other a few times. We've been over the last week. I reached out to Ghaith last Monday with an issue, and the next morning I was there. And an hour later, I had a bone marrow biopsy. And an hour after that, I had a phlebotomy, a therapeutic phlebotomy, which helps this condition. It gives you an idea that they're practicing the type of medicine that I practice. And they're also doing research in addition. I think that is just monumental in terms of what they're able to do and the perspective they bring to it. You can't be a phenomenal researcher unless you look a patient in the eye and see what they're going through. And I know that the two physicians that are on the call with me tonight do just that. And I think that's where I'm so passionate and so lucky to have met the people that I've met, to instantaneously be on this phenomenal board. The Dr. Silver, some of his family members, and some other physicians and leaders in this field allow me to lend my voice. And I'm just really, really honored to be there.
Jeff, thank you for sharing that with us. I know it's difficult to talk about those kind of things, and I think the audience will find it really meaningful. So we're grateful for you sharing that with us. Let's talk a little bit about the research that's going on in this area. Joe, you want to talk a little bit about the first FDA-approved drug? What's the relationship between that drug and weight gain, and just your general perspective on ruxolitinib?
One of the most common mutations, or actually the most common mutation in myeloproliferative neoplasms, is a mutation in a gene called JAK2. JAK2 is involved, it's kind of a client of many of the receptors that signal to promote blood cell formation. And this mutation tends to make that JAK2 client hyperexcitable so that it can stimulate cells with low amounts of cytokine or even no amount of cytokine in some circumstances. And so this discovery of the mutation led to the development of drugs inhibiting JAK2. Ruxolitinib was the first one that seemed safe in patients and had activity. The primary activity was identified in patients with advanced myelofibrosis. So these are patients who are generally characterized by having a lot of constitutional symptoms, including weight loss, very enlarged spleen, sometimes low-grade or even spiking fevers, drenching night sweats, and progressive blood count abnormalities. And ruxolitinib in that setting was found to do two things. Very quickly, it made people feel better. So many of the symptoms went away or were reduced, and it was able to reduce the size of the spleen, which in itself could, in some patients, reduce symptoms. And one thing that was observed in the early studies that led to the approval of ruxolitinib in myelofibrosis is that patients gained weight. And this was thought to be a great beneficial outcome of the drug. Patients were doing better, they were feeling better, so therefore they were eating more and gaining weight. And what we found as time went on and the drugs gained approval and were more commonly used earlier in myelofibrosis in symptomatic patients, and it was approved as second-line therapy in polycythemia vera, that patients, even patients who were not thin, were gaining weight. And many patients actually, you know, as Jeff was saying, we like to listen to our patients because they often tell us what we need to know and what we need to act on that day. And, you know, many of our patients were telling us with guilt, really, you know, I'm eating like a pig. I just can't, every time I, you know, sit down, I eat a meal, I go and eat some more, and they'll, you know, they're gaining weight and they can see it in their faces. They can see it when they buckle their pants. And, you know, some of them, their spouses are commenting on it, you know, trying to motivate them, but saying, hey, you know, you got to exercise, you can't eat all that junk all the time. And the patients had a lot of guilt. And that kind of triggered an interest of ours, because clearly the story wasn't that patients were feeling better and therefore gaining back the weight they had lost due to the disease. This was patients, even overweight patients, who were gaining even more weight. It turns out that JAK2 is also involved in signaling in the brain under a receptor called leptin. And leptin is one of the ways that our body tells us we've eaten enough. So if you eat a meal, leptin, a fatty meal, the fat cells actually produce leptin that goes back to your brain in the thalamus, hypothalamus, and says, you know, appetite, you don't need that anymore. And what happens, what we suspected was happening, is that ruxolitinib was actually blocking that feedback mechanism. It's very similar to what patients were describing to us. And we looked into trying to do a study to prove that in humans, but it's really just a very tiny area of the brain that has those leptin receptors, you know, less than a square centimeter of cells, maybe a couple thousand total cells. So imaging that in humans was really not going to be feasible. And so we developed a mouse model to study the effect of ruxolitinib on leptin signaling. And we were able to find that, you know, or prove that ruxolitinib actually does get into the brain. It actually does cut off this leptin feedback signal. And it, you know, for that reason can increase appetite. You know, why is this important? Is this just, you know, a game? The motivation was to give patients information and to give patients the power to know that when you're taking this drug, it will increase your appetite. And so that knowledge can be acted on. And so before I ever give anybody ruxolitinib, I tell them, look, the likelihood is that this drug will increase your appetite. So you need to carry with you lower calorie, healthier snacks so that when you need to munch on something, because you probably will, it's something that's better for you. And then we keep a close eye on patients. And what we found, and we developed a model that was predictive of those patients who are going to gain significant weight. And we found that patients who gain more than a few percentage of their starting weight within the first 2 months were likely to gain a lot of weight. So the median was up to about 10% of their starting weight patients were gaining. And so we know that if patients are on that trajectory, we need to act. And so that's where sending people to a dietitian, getting physical therapy or a gym membership can all be beneficial to maintain and reduce their cardiovascular risk. And why is that important? Of course, MPNs are characterized by increased cardiovascular risk. So we don't want our therapy to be working against our goals. And this was research that, we put together in relatively short order. And this is the sort of thing that the generous support from CR&T has enabled. To put together a grant to study this is really infeasible. And yet we're able to provide this and publish it and share it with other physicians and share it with patients so that they're aware of this side effect and can be empowered to come up with a plan to deal with it.
Joe, that's fascinating and certainly a tribute to your work and having the time and funding to get something like this done and recognizing the impact it can have on your patients that may have taken years and years and years in just the standard population to find out. Ghaith, just to get your perspective on research, maybe you can tell us a little bit about evidence using interferon prolonging survival compared to standard therapies, including hydroxyurea and phlebotomy.
Certainly. So one of the most controversial issues in polycythemia vera has been whether or not patients should be treated with phlebotomy alone, which is a procedure of bloodletting in order to reduce the red blood cell count, or whether polycythemia vera patients should be treated with a drug that reduces those red cell counts, typically the drug being hydroxyurea or interferon alpha. And so this has sort of been a controversy, I would say, for decades, dating back to the early studies in polycythemia vera in the 1960s, 1970s. I would say that in our institution, of course, under the leadership of Dr. Richard Silver, this wasn't really much of a controversy because under our hands at the center, interferon alpha treatment of polycythemia vera has been very effective at controlling the disease, at reducing the red cell counts to levels that are safe and levels that allow patients to live long, healthy lives, free of some of the complications of this disease that include blood clotting and also progression to a condition called myelofibrosis. So through our experience at our center, this seemed to be the case, and other centers across the world, some have had similar experiences and findings with this drug, and I would say this is sort of in several countries in Europe. So the issue about this controversy remaining a controversy is that there hasn't been a clinical trial that compared interferon alpha head-to-head to one of these interventions such as hydroxyurea or phlebotomy only until very recently. I would say in the past 5 or so years, we are starting to see clinical trials emerge that compare these treatment modalities to one another to determine which one is actually more effective at treating the disease. Now, in the short term, all of these modalities are relatively effective. They can bring down the red cell counts like you would hope, and you can achieve a red cell count control with either of these modalities. But the challenge here is that, this is a disease that, lasts a long time. Ideally, we would want to see patients be in remission and as close to a cure as possible. But the reality of it is, just like having high blood pressure or other medical conditions, this is something that sticks around. So we really want a treatment that on the long run could provide patients with the most benefit. And the challenge here is that polycythemia vera patients live long enough that clinical trials would have to be conducted over many years, sometimes decades, in order to be able to detect that difference in survival, living longer, or living longer free of the complication of myelofibrosis, which is not a very common thing to happen within the first 10 years of the disease. So therefore, our study had provided us with an opportunity, or I should say our experience provided us with the opportunity to look back over the past 30 or so years to see whether or not patients who were treated with interferon alpha did in fact live longer and healthier lives than patients who were treated with the other standard modalities, which are phlebotomy alone or hydroxyurea. So looking back at all our patients, we were able to find 470 patients who were treated here. And it turns out that patients who received interferon alpha for at least a year actually did better than patients who were treated with hydroxyurea or phlebotomy alone by having a lower risk of developing myelofibrosis and living longer overall. And these benefits were actually independent of other factors that can affect longevity. So our study had accounted for some of these factors. And we found that the longer the duration of treatment with interferon, the higher the benefit. And so this is somewhat practice changing. I think, at least for us, definitely it confirms that what we've been doing for 30 years is the right thing to do. But I think it would be practice changing moving forward because some of the important decisions to make in polycythemia vera treatment is a patient who is young and may not have a compelling reason to be on a drug would be treated with phlebotomy alone, in the community and in many academic centers. That's really the standard of care. We feel like phlebotomy alone doesn't actually address the root cause, and it's sort of just like a Band-Aid on the wound. It doesn't really treat the underlying cause. And so our data suggests that there is an investment in the future of the patient by giving them interferon alpha early, even as young individuals who may not have your classic risk factors to consider them high risk in order to treat them with a drug. And so it's practice changing in that sense, but also when it comes to deciding between the treatment options, I think in many community practices and academic centers across the country, hydroxyurea is still very commonly and frequently prescribed, and it is not our first option of treatment. It is not generally the thing we recommend first.
Thank you, Ghaith. Ghaith, while you have the floor, why don't you, if you would, to the listeners, maybe wrap this up, maybe some closing comments. I'll ask the same from Joe and Jeff here in a minute. Share some of your perspectives, maybe some take-home messages that you think is important for our listeners.
Certainly. I think that MPNs in general are a very interesting group of diseases biologically and very complex. As Joe had mentioned, it is sort of a complex biology, but there's a low-hanging fruit in there because once this complexity can be deciphered and resolved, there's really one mutation that once we find a drug that can treat it, we can really impact the lives of patients, similar to how CML has been treated over the past decade or two. We have found that sort of novel wonder drug that puts this disease into remission. And we're hoping to get to that also in treating MPNs as a group of diseases. I think the biology is interesting. I think patients are definitely a pleasure to have in the clinic and to learn from, as well as teach and inform about the disease. I think that our goal is, together with the support of the patients, the support of organizations like CR&T that fund research efforts, and with our own skills and abilities, that we can move this field forward towards the goal of, again, making patients feel better, live longer, and ideally be cured of this. So I think that we all need to contribute in one way or another. And there's many ways to contribute. And so, you know, Joe and I and the Richard T. Silver MPN Center are more than happy to, you know, provide our consultation and our expertise for patients with MPNs, you know, not only in the tri-state area, but even nationally. I think medicine has evolved in the past couple of months to include you know, virtual patient visits. And so we do see patients virtually as well across the nation. And we're happy to provide our expertise and services for such patients.
Thank you, Ghaith. Joe, what would you like to add to the closing comments that you think is important for our listeners this evening?
I think just the center as a whole aimed to provide outstanding clinical care to our current patients, to provide interdisciplinary care. We work at a very rich medical center in the sense of we have experts in many areas who, due to the volume of patients with MPN we see, actually become experts in themselves in the dermatologic or pulmonary or cardiovascular complications of these diseases and help us with management. I think that we are actively engaged in clinical research to improve therapies that are available to our patients. And we're active in the lab so that we can hopefully achieve our goal of making all of these myeloproliferative diseases like CML, in the success that we've had in terms of turning this into a disease that people kind of forget about. Most of my CML patients, I worry about their hypertension and diabetes. You know, and that's what I would look forward to for our other patients with myeloproliferative neoplasms. I think for referring physicians, it's critical to recognize that these uncommon diseases are not simple, and that the best care is not the simplest care. And this is, I think, what Ghaith was alluding to earlier. Polycythemia vera, you know, classically thought of as having too many red blood cells. And the simplistic solution is take the red blood cells out. It's a little like having a hole in your roof and a bucket underneath it. And the plan is to empty the bucket regularly. But there's other approaches. And what we seek is to really fill the hole, fix the roof, and get people in the house back in order.
Thank you, Joe. I like the analogy. Jeff, bring us to conclusion, if you wouldn't mind.
Sure, Terry. Look, I just, as I said earlier, just really happy to be here. I'm really filling a role as a patient going through this, and I want to advocate for others, educate others. I need my patients and my family and my friends to understand that I'm in really good hands, as you can tell. In the last 30 minutes, I think you understand the breadth of knowledge and the compassion that the two physicians have on the screen. And I just want more people to know about them, honestly. As Ghaith said, virtual visits are becoming a norm, and why can't it be that a vast majority of the MPN community. And I'm on forums all the time, online and social media, and I hear the frustration in the voices of patients that are out there with MPN disease. And I look at myself and I consider myself extremely lucky and fortunate that I've been able to find a group that is so talented in so many different ways. And I want to reach out to those individual patients and let them know there's a better way to be treated. There's a more compassionate way to be treated. And, you know, for many of those individuals, they went through months and months and years of being told everything is fine. And I just want them to know that that's no longer the case. You have physicians who are not only able to treat the symptoms that you have, but treat the underlying disease and perhaps, you know, decrease the likelihood of that disease getting worse over time. I'd love to see a cure for this disease in my lifetime, but I certainly think my goal is to make sure that everyone that has it has the type of quality of life that they and their family deserve. And I certainly know that this team is going to provide that for me. And anything that I can do to help, I will.
Thank you, Jeff. Thank you, Ghaith. Thank you, Joe. I'd like to also thank Barbara Rosenstein for orchestrating this evening, and for Richard Silver and his pioneering spirit and his long-term commitment to this. And then to all of you who will learn more about the CR&T, the Cancer Research and Treatment Fund. We will include links to various websites and so forth, so those of you can learn more about these terrific organizations and these committed, compassionate, and very educated and wise physicians. So with that, we'll conclude and thank everybody for their participation this evening.